The interprofessional meetings are there, if you like, to move the patient along their stroke journey. So every week we all get together to decide upon what that patient is going to do for the next week. And no one individual that sits in that meeting could do that on their own.
Well, I'm a social worker and I work with all my colleagues in the professional team on the stroke unit, and I have to understand the medical background of the patient and all the work that the other professionals are managing to be able to help us all facilitate and expedite a safe discharge from the unit. Now, to do that, I have to listen to the functional assessments of physiotherapy colleagues, to think about the daily living exercises and a person's functional abilities, as well as understanding what they are unable to achieve. For me, I feel it's important that the social worker is a member of the interprofessional team that meets weekly on the wards to discuss patient care, the goal setting for patients, and also at those meetings you gain an understanding of the ward culture and become part of the team membership. If on the assessment finds that the patient meets the eligibility criteria, we do what we call a full care needs assessment, and that governs, in a sense, the discharge pathway from the hospital ward.
We're quite instrumental in looking at the patient's discharge plan. That would be linking with the patient and the carers, but also may involve us doing an access visit. That's without the patient, so it might be to measure for a second stair rail. We may do a home visit with the patient, and that would be to look at how they cope within the home environment.
Very often there's very little link with the community teams. In terms of a person going home with a high package of care, our liaison is with the home care staff, and the home carers go in and alert our colleagues in the community if there were a need for further social work involvement.
The link with the community is very important. We quite often do referrals to the teams that are out there that will provide stroke-specific support on discharge, and we'd be heavily involved in making those referrals.
Time is limited, and one thing that patients need is time to recover, and that can be quite a few months down the line, and there's lots of changes because at the moment we might be discharging people out to a community place, but the things like early supported discharge aren't in place at the moment, so time is being restricted in the acute hospital without the full backup out in the community to support the patient.
Stroke is certainly currently recognised as a national priority, both by the government and also individually by strategic health authorities, because it is an important cause of mortality. It's the third biggest cause of mortality in the United Kingdom. It's an important cause of disability. It's the single most important adult cause of disability, and therefore is important to health services, to social services, but above all to patients and carers who have to live with that lifelong disability. And I think we should be striving to improve our assessment, to improve our treatment, and to realise better outcomes. And that comes through training and education as well as clinical service delivery.